diabetes community of practice. As I've put the prompt in the chat, please drop your name, your organization, and your position. And the icebreaker is, how does your organization utilize data? So this is just going to set the foundation for our conversation. It's going to be everything about data and what we are doing in the district, and giving you guys an overview of all the great, a report out of all the great work that all the agencies that we're doing here in the district as well to make DC the healthiest city in the country. All right, Tyler said to improve chronic disease programs. Yes, most definitely. I would say data helps us identify care gaps as well. All right, data is used to show impact and additional grants. Yes. To design and implement evaluation intervention. Yes. These are all great things. Data serves as many, many purposes. We're just going to give it a couple more minutes, have more people come in the chat. Want to be respectful of everybody's time as well. But once again, I say thank you for joining. We greatly do appreciate joining us every month during our community of practice. Also to see which communities need us the most. Great job, Tyler. Definitely. I'm gonna give us like one more minute because we do have a packed agenda. And like I said, I definitely want to be respectful of everyone's time. Just so you know, this meeting is recorded. It will be a reference for everyone afterwards. You know, I send out those recap meetings with all the resources that we have that we present during this meeting. You'll get those in an email. And I just want you guys to be thinking at the end of the meeting, if you have any programs or events that are happening, the last 5 minutes of this diabetes community of practice, we'll definitely go through those, and you can share any upcoming events that is happening. Collaborating with others for their data. Yes, that is great. Sharing is caring. All right. All right. We're gonna jump right into it. Once again, my name is Charlton Brown, pronouns he, him, his, diabetes program manager here at DC Health. Today's diabetes community of practice is focused on data. And this community of practice, we'll be talking about the current state of diabetes, DC Health Diabetes Surveillance Network, diabetes burden in DC, purpose of DC Health Diabetes Program, state of diabetes within DC's reporting network, program strategies, and LinkU walkthrough. So I'm going to allow our presenters to introduce themselves. First, we'll be having the data portion, which will be led by Sharmila and Amanda. And let me.
Hello, good afternoon, everybody. My name is Amanda Hirsch. I'm the Public Health Program Evaluator with the Chronic Disease Division. So I provide oversight in our evaluation activities for our diabetes and our cardiovascular programming. And I am joined for this presentation by my colleague, Sharmila. Sharmila, can you introduce yourself?
Good afternoon. Thanks for joining. I'm Sharmila Chatterjee. I'm the chronic disease epidemiologist here at DC Health, and I provide epidemiological support to the chronic disease programs in DC Health.
Okay, great. Charlton, are you pulling up the slides? Okay. Thanks everyone for joining today. The topic of today's conversation is going to be about leveraging data to inform and evaluate our diabetes prevention and management interventions in the district. Next slide, please. Okay, so Charlton already pretty succinctly stated this, but today we will be presenting an overview on the current state of diabetes in Washington, D.C. We will describe the diverse data sources compiled by the Chronic Disease Division of the D.C. Department of Health to define how, where, and for whom intervention efforts should be focused to address diabetes incidence and control rates. We will also walk through evidence-based strategies that the district has employed to reduce new cases and improve the management of existing cases, and discuss how we leverage data to test and evaluate our journey in getting there. Next slide. At DC Health, we leverage a combination of nationally available data, DC Health internal data, and data from our partners to understand public health priority issues at different levels of granularity, from a high-level snapshot of disease prevalence and mortality to district-wide and health system-level observations of individual modifiable and non-modifiable risk factors. Combined, these data sources allow us to describe the issue of diabetes from top to bottom in a way that, as we will discuss throughout this presentation, is actionable for us as a health department and for our partners as well. And I'm now going to pass the mic to my colleague Sharmila to present at a high-level overview of what these data points have conveyed about the state of diabetes in DC. Next slide, please.
Thanks, Amanda. So we will begin with with our most recent data, which is 2023, and this data has come from the behavioral risk factor surveillance system as well as from the DC vital records. So here, what we see in this graph, the red bars are the DC rates, and these are the mortality ranking of all the top 10 leading causes of death in DC in 2022 and 2023. So if we see here in 2022, diabetes was the seventh leading cause of death in the district. But in 2023, it has moved up in its rank, and it is now the sixth leading cause of death mortality in the district, which is not something which looks very optimistic because it has really come up in its ranking. And even if we compare it with the national mortality rates here, nationally, diabetes still is the seventh leading cause of death. So in terms of comparison to national rates, if you look at in DC, diabetes is the sixth leading cause of death. So this is something that we need to take note of. Next slide. This slide provides a snapshot of the overall burden of diabetes in the district. The overall prevalence is about 7.4%. And if we look at the trend here, it has been slightly on the decline. If we look from 2022 to 2023, in 2022, it was almost about 8%. It's about 7.24% now in 2023. And this is our target where we want to reach. And if we compare the overall DC rates with the rates of the African American population who bears the highest proportion of diabetes in the district, it is pretty high. Where the overall prevalence hovers around 7 to 8%, the rates among the African American population hovers around 13 to 15% here. This is the geographic distribution of diabetes in the district, and as we see here, wards 5, 7, and 8 bear the highest burden of diabetes prevalence in the district, with ward 8 having the highest diabetes rates in the district. If we go by race ethnicity, if the overall prevalence of diabetes among the whites is about 2.6% compared to about 13.6% among those who are Black or African American residents. So it's almost about 6 times higher than that of the white residents in the district. Income, education, and employment status play a role in the overall prevalence of diabetes, with highest prevalence of diabetes being among residents who have lower income, that is less than 50,000 per annum household income. If you look at the employment status, those who are unable to work or those who are retired, they bear the highest burden of diabetes in the district compared to those who are employed. And even those who have lower level of education, that is high school or less level of education, have a higher prevalence of diabetes compared to those of the college graduates. And why is this important? Because this allows us to identify our target population and our focus and our geographic area where we need to focus our programs so that our programs are effective and can be implemented, bearing in mind who we need to focus the programs on. These are some of the risk factors, and if we look at these risk factors and the prevalence of diabetes among the risk factors, individuals, residents living with obesity in the district bear a higher proportion of diabetes, have a high prevalence rate of diabetes compared with those who are normal weight. And it's only about 3% here compared to 17.5% among those who are living with obesity. Smoking also has some relevance to the prevalence of diabetes. Never smokers have a total prevalence of about 6.7% compared to a higher proportion of diabetes among those who are current smokers. And physical activity is another important risk factor. We all know that individuals who do not engage in physical activity have a very high proportion of prevalence of diabetes among themselves compared to those who participate in regular physical activity. It's almost about more than 3 times higher compared to those who participate in physical activity. So these are some of the modifiable risk factors which can be targeted and which can be prevented and which can be taken care of so that the prevalence of diabetes can be decreased among the general population. And with that, I think Amanda, you would take over.
Sure. Yes. Next slide, please. Okay. And we're actually going to skip ahead one more slide. Thank you. Okay. So we've heard now about the state of diabetes in DC, and I want to center us on what the Chronic Disease Division's aim is to address the issue. So the Chronic Disease Division of DC Health aims to reduce the incidence of new diabetes cases and improve control rates among existing cases to ultimately impact the disproportionate diabetes-related morbidity and mortality rates that have more or less persisted over time. I am not a numbers person, but I appreciate the story that numbers tell. And when confronted with a public health challenge such as this, we're tasked with answering a question that really indicates what the data is telling us. And that is, for whom and where should change be sought, why the problem to be addressed exists, and how change may be pursued. And lastly, how we can evaluate if change was achieved. And the role of numbers or data in this work is to parse out what contributes to this observed burden of disease, as well as to provide a basis for intervention planning and to test the extent to which the process and impact of our intervention activities were achieved as anticipated. Next slide. So when we think about tackling this issue that the data is signaling from a programmatic standpoint, we really need to put on our health equity hats. And I think everybody on this call can agree that we know that the broader population's health is really contingent upon strategically addressing the needs of those with the greatest burden of disease. So here's a visual representation of how we've layered the various data sources that Sharmila presented to define the socioecological context of the diabetes burden in DC, and more specifically to pinpoint where and for whom resources should be allocated by the district and by our partnering organizations by assessing what demographic, socioeconomic, and place-based conditions contribute to the disparate outcomes that we see year after year. Next slide, please. And this is, I think, an exciting part for all of us sort of program planning folk on this call, is how do we apply data to define the how in our program management progression? So we leverage this data-driven socio-ecological narrative to define how we may curate our approach to intervention at all levels. We take what we know about the who, where, and why, and we put on our public health program hats to determine that programmatic how. So the Chronic Disease Division has identified these three quote unquote buckets of intervention that the literature suggests will advance the equitable and effective delivery of care for people who uphold the characteristics that our data describes. Some of these might look familiar to you. First is the expansion of access and participation in evidence-based lifestyle change programs, including DSMES or Diabetes Support Management and Education Services, and DPP, Diabetes Prevention Programs, as the literature and lived experience of community members suggest that residents at greatest risk for diabetes yield better outcomes when provided culturally adapted competency building education and support, when clinical intervention alone appears to be insufficient. Second, the expansion of DSMES and DPP services in the high reach and high touch pharmacy setting, where we have an opportunity in front of us to capitalize upon the familiarity and the accessibility and the clinical expertise of the pharmacy and the pharmacist to deliver prevention and management services to those who are disengaged or less responsive to conventional care. And lastly, to support a culture of chronic care management where the upstream social determinants of health are weighted as equal to clinical risk factors in predicting health outcomes, integrating access to the robust social resource landscape that exists in the district within the clinical setting to address unmet social needs that ultimately impair self-management. And I have a quote on the right here, which I really like, which is that on average, a person with diabetes spends less than 1% of their life with their healthcare team. So the question is really, what are we collectively doing to improve their ability to mitigate their disease in the 99% of their lifetime days that they spend outside of the healthcare setting? Next, please. Okay. And in the last portion of this presentation, I'm going to describe how, as we move through the implementation phase of these strategies, we continuously call upon data to evaluate whether or not or to what extent we're successful in rolling out our program as intended. It is here in the early implementation phase of our strategies that our partners are invaluable to give context to the broader district-wide data that we compile and conveying to us what processes work, what doesn't work, where opportunities for future testing of our theories arise, and in what ways our strategic approach may be confirmed as effective to improving diabetes outcomes or require more modification as we look toward measuring our projected program outcomes down the road. Next slide. So again, we've described how we've used data to define our priority population. We've described how we've leveraged data to sort of level set against the literature to decide on what types of interventions may be optimal for the populations that the data indicates we must prioritize. And now that we're all, I think, collectively in the implementation phase, I want to talk about how data informs the evaluations of those sort of strategic buckets that I've just described. So for those of you who don't know, I'm going to give a little insight into the district or chronic disease division's approach to evaluating each of these strategies. So under strategy 1, we'll call it, which is the expansion of diabetes self-management and support programs in high burden wards, we're aiming to assess the impact of the strategic placement of these services within high burden wards upon participation in diabetes care. So our theory here is that expanding availability of services will therefore increase, of course, the possibility of touches between a high-risk resident and a healthcare provider. Another component of this evaluation work is to define organizational best practices. So this is at the health system, pharmacy, or CBO level, and TA needs to establish and scale their respective diabetes support programs. And ultimately, of course, to determine the impact of this expanded access and increased resident participation upon outcomes in high-risk populations. Next, please. So we have the goal to operationalize at least 16 diabetes self-management programs and to reach a collective 5,000 priority residents each year through the end of program year 5. Our theory, again, being that increased access to evidence-based lifestyle change programs will improve health outcomes among residents for which usual care doesn't appear or is sometimes not sufficient per what our data is telling us. And on a high level, we're testing this success by monitoring the volume of available DSMES programs, which are those red columns there, as well as participant enrollment over time, which is the gray line on that bar graph. And we're applying geospatial mapping, which you can see on the left, to affirm that these services are placed where they needed most, to ultimately validate whether the expanded provision of services within high burden wards is truly an effective means of engaging high risk populations as theorized under this strategy. But the bulk of our evaluation work at this stage of intervention is really more about assessing what happens in between those annual benchmarks and to see the extent to which our activities, including the provision of capacity building, technical assistance, and resource sharing, and the experience of our partners as they stand up their programs, contribute to the availability and reach of services. And we monitor these trends throughout the implementation phase in the form of grantee reporting and patient level program records to tell us in real time what has facilitated or posed a challenge to our partners while they're in the process of tailoring, scaling, and effectively delivering their respective DSMES programs. Next slide. Okay. Our evaluation of strategy 2, and again, this is about scaling and sustaining pharmacists as extensions of the chronic care continuum. Our evaluation approach to this issue of pharmacy-based program expansion is to develop and test models of these program delivery in the pharmacy setting, to define what the barriers and facilitators to sustaining this model in the pharmacy setting are, and to impact pharmacy-based program and to examine the impact of pharmacy-based program completion upon diabetes outcomes in high-risk populations. Next slide. So we theorize, as I've mentioned, that extending the continuum of chronic disease programming through the pharmacy setting will further enhance the reach of prevention and management services to those that otherwise are under addressed in the clinical setting. Similar to our DSMES strategy, we test our success by monitoring the volume of available pharmacy-based programs and participant enrollment over time. However, incorporated into this evaluation work as well is an examination of the upstream considerations to sustaining the pharmacy model, because again, through this work, we are testing to see what this model looks like and how it can be continued on. And so through this testing, particularly as it relates to program structure, financing, and pharmacist inclusion in the greater health education landscape, we layer these considerations into a set of unique process measures that quantify the development of shared infrastructure, the solidification of billing systems and reimbursement policy, and the widespread uptake of technologies that facilitate communication between pharmacists, health systems, and referring community-based organizations that are compiled through the implementation phase to demonstrate to us at this stage, again, what is necessary to support and sustain this unique model of care delivery. Next slide, please. And then lastly, strategy bucket 3, which is about promoting the use of multi-directional e-referral platforms. In our case, that specifically is LinkU. To assess the extent to which use of LinkU has decreased the volume of unmet social needs within our priority population, and to validate our theory that social service support needs do have an impact one way or another on health outcomes, particularly as it pertains to chronic disease outcomes, and that the mitigation of social support needs or meeting of unmet social support needs will have a positive impact on resident health. Next slide. So we theorize, and I'm sorry if I'm repeating myself, that fostering a district-wide network of clinical and non-clinical resources and supporting the utilization of LinkU to facilitate cross-collaboration between these resources will enhance the scope of care received by residents with diabetes. Through this work, what we're ultimately testing is if the fulfillment of unmet social needs contributes to improved health outcomes among high-risk residents. And this will be measured through LinkU social needs data captured within the context of clinical outcomes within agency EHRs. In the interim, however, our data sources and corresponding indicators reflect the upstream processes undertaken by clinical and non-clinical providers to integrate the use of LinkU within their existing technologies, such as their electronic health records, and within their chronic care teams. These process measures derived from a compilation of LinkU and health system level data indicate a change in the volume of agencies claimed in LinkU, the number of residents that are screened and referred for social needs in LinkU, and the number of social need referrals closed. And combined, these indicators, I think, tell us an important story about the district's sort of large-scale change management approach to advancing the role of health systems, as I think I suggested earlier, in a culture of documenting and accessing social need data to inform the provision of high-quality diabetes care. And this is, I think, a really good intro to our guest speaker, but I just wanted to these maps here don't quite correspond with this strategy, but I wanted to demonstrate the map of the District of Columbia on the left. Those little orange red dots and the white squares indicate where our priority populations serving FQHCs and pharmacies lie. And I want to take a look at the right, which is the progression of poor diabetes control among district residents by census tract. And we see that the prevalence of poor control is sustained or it persists within certain census tracts over time. And although our partner FQHCs and pharmacies are strategically located in the areas where residents need them most, as I think has been indicated by the data, the sheer volume of residents at risk for worse diabetes outcomes outweighs the capacity of our partners to an extent that that we believe sort of integrated cross collaborations externally or taking advantage of the, again, as I've said, robust social resource landscape and clinical care landscape that DC has to offer will help bring the supply of diabetes care providers or sort of ancillary care supports needed to improve health outcomes closer to the demand as across district residents. So without further ado, I think I have one more slide. Oh, it's a thank you slide. And I do want to, we have a couple minutes for questions. I also had a few prompts that I would like to pose to the group if anyone's brave enough to share. Based off of what you've heard today, our team would like to know if there are any additional data points or any other sort of avenues of exploration that you feel may be helpful to incorporate into the chronic disease division's evaluation of its diabetes programs. And the other question that I'm posing to the group, and we don't necessarily need answers to both today, but are there any data elements that you've seen today that you believe would be helpful to have access to incorporate into validating your organization's work in the chronic care space? Okay. I'll ask a maybe an easier question, and maybe people can just throw up a thumbs up or some indication. My goal with this, again, because I'm really like not a numbers person, is to talk about sort of how to make data an interesting story. Is anybody thinking about the data that they collect in their respective programs, thinking about maybe ways that they can refine their data or plan for their data to make it more interesting or true to the objective of the programs that you all work in?
Hi, Amanda. This is Vivian with Soul.
Vivian.
Hi. This is based on your first question to the group. I was wondering if the city is collecting any data on access to food, nutritious food, and chronic disease management and prevention. I would refer to mostly diabetes and hypertension. We do know there's several initiatives in the city like Produce Plus. We also know about MCOs providing medically tailored meals with Food and Friends or Mom's Meals. But is there any kind of data to evaluate these programs to see if it's actually having an impact in not just preventing complications for those who have the disease, but also preventing as well? I think it'll be interesting to see the impact of these programs in improving the overall health and the prevalence of chronic conditions like diabetes and hypertension in the district.
I can chime in here, Amanda. Sharmila. Can you hear me? Hello?
Yes, we can hear you, Shannon.
Oh, you can. Okay.
Yeah.
So yes, there is some evaluation that happens on the program level. But I will say, I think one of the challenges around evaluating the impact of those services on the clinical outcome is that often residents that are experiencing food insecurity are also experiencing other challenges. And so it's difficult to evaluate the direct impact on the clinical outcome, because there may be like other, sort of competing challenges or barriers that residents face. I think that's one of also the benefits that we have for being able to see like BRFIS data and other district-wide data, because when we're evaluating the impact of programs, we're able to see, what are some of the other SDOH or social need barriers that could be either skewing or impacting a service's ability to, improve an outcome. So we can definitely connect with those programs, Dr. Yuk, to see what's available to support you. But yeah, I did want to put it in, provide some additional context for those numbers.
Thanks, Shannon. I appreciate it. It's just curiosity, though, because we're going to be engaging in quite a few of these activities in the next and partnerships in the next couple of years. So we want to know, if there is any data tracking, we're going to do our part to provide what we have. But it'd be interesting if we could just have a citywide data collection to see what impact nutrition or lack of has on improving those health outcomes, because we do know research tells us nutrition plays a huge part in disease management. So it'd be great to know what all those different things we're doing in the district, even if it's just correlation, do we have any kind of data to let us know that this is money well spent and these kinds of initiatives should be expanded, scaled, or should we be looking at different types of programs to assist residents, because we want to do things that make sense and work.
Yep. And Amanda mentioned also on sort of this metadata level, we are, so we're working with our health system partners and the district's HIE CRISP on integrating LinkU, which is the social needs screening and referral tool that we've endorsed, integrating that into CRISP, which will be accessed through a single sign-on in the EHR. And so that'll reduce barriers for screening and referral in the clinical setting. And it'll also allow for the integration of the data, speaking to what you just mentioned, Dr. Yuk. So we'll be able to see how, what the impact of these screenings and referrals are within the clinical context of the patient. So we'll see, does this patient with a history of poorly controlled diabetes who has had food insecurity and transportation barriers, now that they have been identified and addressed, is that having any impact on this patient's diabetes control? So that is something that we'll be able to see and pull in CRISP.
Thank you, Jen.
Any other questions before we pass the mic to Jason? Okay.
All right, Jason, the floor is all yours.
All right. Hello, everyone. My name is Jason Edmonds. I'm here on behalf of DC DOH's HAHSTA team. And I'm the interim LinkU program admin until our great Ashley Coleman comes back from maternity leave. So I've been in this role for a few months now, since December. And it's a lot of information to go over. So the team here just asked me to focus on 5 bullet points. So forgive me if I don't cover all your questions, but I just put in the chat the link to the video on YouTube. It's 52 minutes, and it's a more robust explanation of LinkU and everything that it does. It's a powerful tool for navigating referrals. But I'm going to go focus on these 5 bullet points. And I'm going to switch between my PowerPoint presentation and the sites, because I think I'm more of a hands-on person, so I like rather show you than just show you a site. So I'm going to focus on that. So Charlton, can I share my screen, or is that something?
Yes, you sure can. If you look at the bottom, it should say share. And I definitely appreciate Jason saying that. Just so y'all know, in April, we'll also be having a full dive into LinkU with our Find Help representative. So just make sure we're using this as kind of like the foundation. Make sure we're reviewing the videos, sharing the videos with your organization, and then come next month, we're going to take a deeper dive of getting real deep into LinkU. Go ahead. Sorry about that.
All right, thanks. So it's in the loading wheel. Let me know when you guys can see it. Okay, well, let me. Trying to get it to share my screen. Let me just try again. Okay. Yeah.
If it's not working on your end, Jason, you can send it to me and I can share it for you.
Okay, I'll resend it because I'm trying to pull up the PowerPoint and it's, oh, there it is. Let me see now. It just needed to load itself. Can you see it now or?
No, sir.
Okay, I'll share it with you. Sorry about that, everybody. I actually sent it to you via email, but I wanted to pull up the website initially. So that's the screen I wanted to share, but
I also have the website pulled up as well, so I can share that as well if you'd like. And if you'd like,
okay. Okay. Yeah, can you pull up the PowerPoint? Because sorry about that, frozen.
Yeah. So we didn't receive a email from you.
Charlton, I sent it to Charlton Brown. That's you, right? I
Yeah.
resend. Yeah, let me resend it again.
It's under my email. Just sent it at 2:14.
Yeah, send another one. Okay, you have it.
Yes, I'm sharing it now.
Thank you. Okay. So again, Jason, I'm going to go over these bullet points. So, okay. I'm going to go over how to claim an organization on LinkU, how to search for programs, how to navigate LinkU as a community partner or CBO, and how to navigate the referral process and track referrals. So the training link, I've also copied and attached in this in the chat here. So if you want to reference that, you can just click on the link there to send you directly to that video I mentioned earlier. That's on YouTube. And I'm gonna go ahead and get started. So can you please go to the next slide? So there are two different sites for LinkU. There's the staff site and the general seeker site. For our purposes, I'm going to focus on the staff site because that's the more analytic driven site of the two. And there are different types of users that interact with this platform. And so I'm gonna go over those types of users before I get into the claims process. So the first type of user is a navigator or staff, and the purpose is the purpose of those are the members of an organization who use the platform to help find resources for seekers, and they also have access to site reports, and that's vitally important. There's also the site administrators, which I am, because I can add or remove users, and I can have access to specific tools, and I manage the platform. These people are responsible for provisioning users and adding groups, customizing the site, and featuring programs. Then you have the group managers. So I recently added a group, a community-based group yesterday, and it had 16 members, and you can create different access levels for each member of that group. This allows them the ability to manage the platform. And the group managers are responsible for adding or removing users from specific groups within the site. Then we have the program worker, and the program worker is also a member of the CBO that has been added to a particular program and has access to inbound referrals and program tools. And then finally, we have the program administrator, and that person is also a member of a CBO that has additional access to edit program listing and to add and remove program workers. So I'm gonna go ahead and jump into how to claim someone on the claims page. So to access the claims page, Charleston, could you share the website? I'm sorry, I want to go back to that.
You need me to go back to the website?
Yeah, it's the easiest way, because I'm gonna speak through it. The video goes through it as well. If you look at that, it's towards the end of the video. But if you're on the staff site, which is the URL, the URL is linkustaff.findhelp.com, and then the general site is linkudmv.org, and those are just for the seekers, so potential clients who need to be referred to services. So if you're on the LinkU staff site, if you scroll all the way down to the bottom and click the claims programs button, you can find the claims. You can join the claim. You can claim your program. So what I was going to do before I had some technical difficulties, I'll type in DC Health. I will be able to claim my own program, and you can verify whether or not your program has been claimed after you go through these steps seen here on this PowerPoint presentation by you'll see a little check mark next to your agency. And if you don't know your program and you just want to search for it, you can also just do a general search for your program and suggest a program. So if you don't think the program has been claimed, right next to at the very bottom of the website, it says suggest programs and claims program. And on the suggest program, if you do not know that that agency or program is available on LinkU, you can suggest them, and the platform, Find Help, will create the connections and search the entire network, and to make sure that program is or isn't available, and they'll provide feedback for you for that. So that's a great resource that we have available to us through LinkU. So yeah, you go search for your program, as I have here in the PowerPoint. You enter the name of your program. For this purpose, I would enter DC Health. I would select my program from the search results, and then I would choose the program that I like to claim, and then click the claim button. From then, if you don't have an account, it will prompt you to create an account. So you will provide your name, your work email, and create a password to set up an account. And then it'll send you a verification link, of which you will click in your email and verify it and follow the instructions from there to confirm your account. From then, it'll go through the entire process of the claim. All right, I'm going to the next one. I'm sorry.
You can see my screen, correct?
Yeah, I just see the PowerPoint. I don't see the website. So maybe I'm not using the right web browser to optimize my share screen. So please forgive me.
Oh, I just see the PowerPoint also.
Oh, okay. Okay, so how to search for programs. This is the part of my presentation where I would again jump back to the website. When you go to the website, the LinkU website, either the linkudmv.org or The staff site, it basically navigates the exact same way. The only difference is the access to analytics that the staff site provides as opposed to the regular site. You would enter your zip code. So right off the break, there's a general page, and then they have a if you click on the DC Health button, it takes you already back all the way to home. So you'll be prompted to do a social needs screener. We'll get to that later. But before then, it'll just say, welcome to LinkU, find health, food, housing, and more anywhere. Let's get started. You can either like type in what you want to find, i.e. food pantry, or you can just type in the zip code that you want to search in. And the great thing about that is if you have a potential seeker who is looking for a particular service that isn't in the area, or they're going to another area, say they're relocating to North Carolina or New York, the great thing about this platform, it still finds these kind of programs for you no matter where you are in the United States. So, and it refers you, if once you complete that social needs screener, it keeps their profile in the system, and everyone in your group can view their profile if given the proper access. So that's the beautiful thing about LinkU, is that these referrals carry on with that individual throughout their journey, wherever they are. It's not just specific to the DMV. So then you can browse categories. And once you see all the programs listed in the categories, you can verify whether or not they've been claimed by that check mark that is next to their name. You can even enter keywords, specific keywords related to whatever it is you're seeking. And then you can review the results. And then if you already have your account created, it saves all your search history. So you can create a specific URL to all your saved programs and share it with everybody in your group, or that you can just send it to a client you might be referring to as well. Say, hey, I think these are the things that you might need. Here's a link to these particular programs that I think you should be interested in. And they can just go directly to it without having to do their own search. So that's also a great tool that I would like to show you, but we have technical difficulties here. So, and so the list of programs matching your criteria will be displayed, including details like services offered, eligibility, and contact information, as I spoke of earlier. Next slide, please. Okay, so there's a lot of different tools, robust tools, and we're short on time, so I'm sorry. I'm gonna have to speed through this. There are a lot of different tools you can use as a community partner. One of which being the claim and manage programs. I already went over the claims program prior. We'll go over the managed programs. You can use the My Program tool selection to update your information, manage referrals, and access reporting features. And again, these referrals carry on with your group, and you can share them if you have the proper access. You can collaborate with other organizations. You can engage with other community-based organizations within the LinkU network to coordinate services and share resources, as I said before. And you can utilize support resources. So you can access training materials, how-to articles, and support through the platform support portal, which I'm going to talk about earlier because that was another talking point, for assistance with site features and best practices. Next slide, please. So this is the most knowledge intensive. I guess this is the most robust part of my presentation. So this is how to navigate the referral process and track referrals. So when you receive a referral, or when a referral is made to your program, you will get a notification via the email associated with your account. Then if you want to access the inbound referrals, you log into your account, navigate to My Program tools, then you go to inbound referrals to view new referrals. And then if you want to update the referral status, you can do it directly within the platform, which helps with tracking and reporting. And again, if you update it and you want to change it back, you can also do that. It's not static. You can utilize support resources. You have access to training materials, how-to articles. Again, and support through the platform support portal. So if you get lost or you don't know really how to access stuff, you can go to the support portal. It's on the LinkU site, or whether it's the staff site or the general site, and you can get access to a robust amount of information. They have videos and training resources available for everyone. Next slide. So, so in regards to the support portal, a key point that they asked me to talk about is providing feedback to LinkU. So if you go through the support portal, you can find how-to articles, training materials, and feature updates, but you can also contact support for specific issues, like if you have login difficulties, if you have problems claiming your programs, if you have technical problems, if you have an issue connecting with LinkU's team, you can go through the support portal. And the final thing is you can provide suggestions. You can use the platform's feedback mechanism within the support portal to suggest improvements or report challenges you've encountered, or to add to provide feedback on how you think it can the website can be better utilized. Next slide. And if you have any questions or you need further information, again, I just highly recommend you click that very long YouTube video. It's very informational, or you can contact me. I can walk you through everything via Teams. That'd be a better way to use this. And I can kind of walk you through everything you need to know. And also, it's so many other features that I don't really have time to get into right now, because I know we're strapped for time. We got 3 minutes. But there are like so many things you can do with like connecting referrals, creating lists, saving referrals, data analytics. If you have access to aggregate and PII information, you can do the data analytics or search terms to see where your target demographic and what they're searching for, what they're looking for in a specific zip code. It doesn't search by ward, but you can kind of ascertain the ward through the zip code if you know which wards fit in whatever zip code. So that's also a great tool when it comes to searching for what programs are needed in specific areas. And it's not just specific to the DMV either. So if you have any questions, just feel free to ask.
Thank you so much, Jason. And I do apologize for the technical difficulties, but we definitely want to tie it back to data and how data is utilized with LinkU. So with the platform, being able to pull by demographic, the who, what, where, why, how many referrals are being completed, how many referrals are being missed. This is a way that our organizations can help better their programs and identify where the care gaps are. So in our upcoming diabetes community of practice, we'll be focusing on LinkU. We'll be taking a deeper dive in how to leveraging that data to better assist you in running your programs. And I do apologize once again for the technical difficulties that you guys were not able to see the walkthrough, but definitely with the upcoming follow-up email that I will be sending, I'll be sending out resources. And if you have any questions, we can definitely connect you prior to that meeting, and I can do a walkthrough with you guys and to get a better understanding as well.
And again, thanks, Charlton. Again, that video that I linked in the chat, that is all walkthrough. The entire 53 minutes is just a walkthrough of the website and how to view. And towards like the second half of it, you'll get a more data specific version of it. That the social needs screener is essential when it comes to creating a profile for whoever needs a referral. And it's a really long document, but once that's complete, you can basically have a whole profile for whoever it is the seeker is. And then from that screener, it provides all the programs that the platform suggests programs that person might need. And then from there, once they do the referral, you can close the loop to the referral as well. Once that seeker has found that program and they've done that screening and they've done everything they need to do, you can then go in and close the loop. And then you can see the statistics or the analytics on how many loops were closed and how many are still outstanding, so you can make sure that people are receiving the services that they need.
I want to be respectful of everyone's time here. If you have any upcoming events that is happening at your organization, please feel free to shoot me an email and I can attach that into the follow-up email so everyone can have it, that they can support your event at your organization as well. And I just want to say thank you once again to our presenters, DC Health, and all of our community partners for joining this month's Diabetes Community of Practice. And once again, I do apologize for the technical difficulties. Technology itself is, but definitely, y'all have a beautiful day, and thank you so much.
Thank you. Bye.